It's all about smoke. In fact, we said that the backache, when we talk about backache, it means that we don't think of diagnosis. We think of what could be done, all at the same time. That's what we're saying. It's not staccato. Staccato means one by one. No. You know, this is the difference between emergency medicine and medical or otherwise other discipline, wherein we all at one time, and then time critical situation. So I haven't been doing what you did, but okay, give me a summary.
Actually, 54 years old gentleman was brought by son in the middle of the night with complaint of shortness of breath.
I don't like 54. What do I like?
Middle-aged gentleman.
No, if you know the age is okay too. If you know the age is alright, it's okay. But what's more important?
Elder gentleman.
What's the favorite statement? It's something. There's two things. There is what we call chronological age, biological age, and also most importantly to assist in our visualization. Is it you, or you? Give me the picture so that everybody can be since I do not know
middle-aged gentleman, medium build.
Why are you shouting at me?
Middle-aged gentleman, medium build.
Okay.
Presented. This recently discharged from the ICR 4 days ago. He had pneumonia. Presented with complaint of shortness of breath. 1 day prior to the presentation and the triage.
Okay. So the next sentence is about what? That begins summary means nothing distinct. I still cannot visualize this way. You take it. We have to move on. We cannot focus on this. We have to move on for the thing. But you see, the value of medication management is about the next sentence. So when you describe for me, okay, a medium build 50-something-year-old person, just describe from IPR, presenting to us with this news, yeah? Okay, fine. Now, next sentence is to talk about what? What's the next sentence? Because
The patient.
so what's next?
The patient was brought by the son. One patient having tachypnea related to usage of the muscle. Actually, at that time, patient had his own SpO2 monitoring portable.
No, like although I say it's important, but still, to me, is you see even that also not. You know why? Because the eyes is first, and everything is a second. So if I train you to be sharp at one look, I don't need all that. You know? Okay, thank you. We have a SpO2. I know ultimately important. To me, if I get many of you sharp with your eyes and able to tell me all the details, then you are a safer clinician than having to look at all the adjunct. You understand? The modern doctors, Asaari again, have a lot dependent on this. You know, me, we are older generation. The older generation, we train our eyes. Okay, we train our eyes. Whatever says, that's good. But now, when you describe for me, you must describe for me that you are able to make some form of diagnosis and method. Go ahead, give me the second sentence. Give me the second bracket of the knowledge. What do you think I want? Okay, I can summarize for you now. You have a 54% listening, this is the IPR. It's some form of remorbidity to general attention. Fine. So what's next? What's next? Just give me the summary.
Patient having cough.
Nah, that's not. All that already you say this thing is good enough. Cough is not important, but not. What's more important?
Patient lethargic.
Okay, you said that. Okay, lethargic. Okay.
And speaking process.
Not possessiveness. Okay. Okay. What's next? No need for all those things already. Enough already. This is enough already. Okay, you say lethargic. That's enough already. What does that indicate? Severity. Okay, we are talking about some form of diagnosis and degree of severity. Okay, so what I want next? No, you have to be smooth. I mean, it's all about simple logic. It's all about simple logic.
Disposition for this patient.
Okay, so then you like as I said, you have to be excited. Yes. okay, you can see there. Everything else is okay. All about looking at the patient, the total picture. So the total picture of this patient is you must tell everyone. I've got this youngish person, and he's medium build. You know, he's very dyspneic. And I was told that he discharged from IPR. But I think this patient is in a form of like a degree of moderate to severe, or even very severe, because he is using muscle and he's really quite weak. So then when you already build up the momentum to climb up the ladder of excitement, to activate everybody's senses, everybody say, what's next? You see like the movie, what's next? And you know what I mean? So like that, you know, like that. So you have to feel that momentum. Everybody like, yeah, ready, you know what I mean? What's next? You know what I mean? So what's next?
He was brought to ED and then...
No, what's next is...
was at the research.
Okay. I don't worry, I mean this is suspect, but don't get too excited. I mean this is suspect. Then, okay, now patient is medium patient again, review. Medium patient walking still very weak, and then you know like thorax and like everybody's looking. So you have the feels. See, I mean everybody's looking at the feels.
He was put to the bed.
Okay, then went on the bed. Then come on, quick.
So was put into the...
No, on the bed is not good enough. Everybody's
Prof 45.
Right? Okay, Prof in the...
45 degrees and then...
Prof up in the... Not 45 degrees. In the patient's comfortable position. Now what is the comfortable position for this patient? Okay, you must ask the patient. You must tell everyone. Then make sure don't simply put 45 degrees. What if the patient is so weak and tired? No more, cannot stand anymore, slouching. If patient is slouching, what will happen to the patient slouching and the airway is unsustainable? What will happen to the airway? The tongue will block if you see. Then you may put patient on left lateral position and give a bit of physio so that patient actually, you know, all fluid can flow out or something. If there is, it's a secretion, you think, in this patient?
Yes, it's a
lot of secretion. So if the patient's out like that and his airway is not sustainable, then you may actually flood the patient and the patient may have difficulty. Already so weak, so tired, now fluid in his upper respiratory airway. So you put patient in such something. So this is why, although you look so every time the same thing again, people get fed up, right? But you know you cannot get fed up because you see this is different now. This is different is patient comfortable position, fine. Patient like this, weak and tired and all situation, don't get fed up. You have to do it. And if you don't tell me, I'm not going to allow you to move on because right now we have to. There is a package. Package also put patient in a position of safety. So which one is the best for this patient?
This patient, immediately I did the system specific examinations.
No, from there, from here. Was the patient better off sitting up or right on position? Most of the time people say, short time only, you know, short time only about 30 seconds. Whatever it is, total quality management in the true sense of the word. Everything you do is. I know many of you say, I'm on boring, the same thing over again. But if I don't teach you all the little detail, you are of no different than the rest of the country. We are special. We take care of everything. I remember my famous quotation. The famous quotation sounding like this. Oh yes, okay, this is mine. We do every simple thing well to make the big task easy. You understand? You won't get it anyway. It's my quotation. Why? This is a PQM. PQM is every little thing you do well. You know, if you do everything well, and it is a good second nature, it's a good reflex, everything will be so easy because everything put together. So, why get bothered? Why get upset? Well, I insist quality, so you must tell me. But best position this patient in?
Position on this patient actually was brought up 90 degrees.
Okay, patient brought up comfortable, okay, with a tripod position, supporting using accessory muscle. You put the thing there to support it. Okay, that's no problem. Good. Good quality. Okay. Right, the patient arrived at the cubicle. Okay?
So, upon arrival at the cubicle, sisters had
You have a excitement. Like, you know, when we build up the assessment. Okay.
the specific examination was done immediately.
You don't, in fact, before you do that, okay, you say, you must say things right. Okay, I look at the patient arrived at the cubicle, yeah, patient being brought up using accessory muscle, in fact, very dyspneic, yes, maybe look very lethargic and weak. You see, you build up the momentum of excitement. Everybody now try to interpret. I may pause, not asking you to confirm, I may ask somebody to confirm. What if you see this case? What would you do? Okay, anyone? We'll take one. Hassan. Anyone? Are you together in this momentum? What momentum? Why is all this? Why is better with some Japati and Patukan? Yeah, what? You know what this is all about? It's training. Are you interested in learning? Now it's your show, okay? Because now at this time, this person is not around. I want to make sure everybody must say, what would you do? What would you do? Okay, thinking. Not enough. What would you do? Because we have built up the momentum. Everybody now say, one more time, okay? This medium. Listen to me. Quickly. Okay, everybody, all here. Because I want to make sure that. Louder. One. Good summary.
54. Elderly.
Not elderly. Don't do that.
Middle-aged gentleman, unlike he, just recently discharged from IPR 4 days ago, presented with shortness of breath. If not, for the patient noted in severe respiratory distress, the type of position, using accessory muscles, poor peripheries.
Okay. This is very common. Very common, and everybody like it. You have with you 2 nurses. 1 nurse or maybe 1 PPP. You have. So you are the team leader. If you do not know this, you cannot graduate from emergency department. Because this is one so basic, you must be able to. Okay, who want to say? Quickly, because if you are thinking, it cannot be thinking anymore. It should be second nature. How long have you been in the department? 2 months. You? Okay. You? 1 week? Okay, you got to answer. Come here. 1 week. Okay, you answer first. Let's see. Why I literally you upset? What would you do in this case? Sorry?
Check the respiratory patient and ITM mask for the patient and check the lungs.
Okay, what's wrong? Is that right or not? You should be right. What's wrong with that? What is our, what do we expect? Is that correct? Is that correct? Check, check SpO2, give oxygen. Check the lung. Find the sign. Actually, it's not wrong, but you just have to arrange it, put it together. Okay? You see like that cubicle. Let's say patient is there, the cubicle like that, right? That's it. Okay, prop up the bed. Just like that. Drop out. Drop out. Just like that. So everyone, now focus. Visualize. One youngish patient. Youngish, okay? Youngish, okay. Medium build. This knee. Prop up. How would you do? You are looking from here. You are requested to look from the bed end so that you can see total picture. You don't want to go to closer patient because you don't see. We start off by looking at the patient total, of course. We go after that, we go and introduce ourselves. Okay? We say, I'm so and so, but before that, you already have got a quick picture of the patient. What would you do next? First thing, we will arrange what she said. It's not far wrong. But we have to arrange it. Okay, after you introduce yourself, what would you do? What do you think the patient deserves right now? This is called package management. This is called package without diagnosis. And sometimes we may not even get the diagnosis anytime. The patient may not get, we cannot get the diagnosis. But we have some the package. Because you can give oxygen, but you can give something much more interventional. You know what I mean? Because depending on how confident you are in the management. Okay. Let's see. Now, too much. We have discussed this case before. If you are attentive, you probably will be. You must tell. Siva, you must tell me whether it's right or wrong, okay? You conduct me down now.
In front of the patient, look how the patient is positioned, how the patient
Already given to tell you. Already told you. Again, he wants to from up. Tripod. Take it late. Already decided.
Patient currently on any diploma.
Your choice. Your choice. Patient just arrived. You are the person
Okay.
there.
First we look at the patient and then we also look at the vital sign that was taken by the
No, no. Vital sign not yet taken. Patient just arrived. You've got 2 nurses beside you.
So I will ask the staff nurse to get the all vital signs.
Okay, you say you ask our nurse to get that. Okay, let's say one staff nurse doing vital sign. Okay.
And then
Still do it. Going to take time. It's not automatic.
I would like to get any MA subject to get investigation, the blood investigation.
You want somebody to do blood investigation? What blood investigation you want to do?
FPC.
Send. Send.
Preparing now sebab beberapa forensik dia calling nak macam
Yeah.
Get an FPC, RP, investigation.
You have asked everybody to do everything and you are not doing anything. Well, you are the most important person. I say I will do this, I will ask person to do it fine. So far, what you say is somebody will be a vital sign, but you cannot get it within 1 minute. But 1 minute, you still have to do something. And you want to do something to the fine, but still, patient requires services. What are you going to do?
I'm trying to get it.
Don't try, okay?
Yeah, I'll
If
get
some-
it.
if your life is at stake, if somebody trying on you, you punch the person, okay? No more trying.
I'll get a brief history from family members around.
Okay, okay, what? So just give a short brief history. You're very clever, you're a politician, you're very clever, working around.
My father, this is from this it is lung patient. So, note that tonight is having a call persistent difficulty breathing.
Based on the service given, I'm thinking of patients in respiratory distress and the diagnosis I would focus on the breathing, respiratory distress. So I will go and check the patient.
The time is up. Because the time is up. Why? Because we got to this one is something that you must you take to a certain point. In our thinking in action. Okay? Thinking in action. Right. What's the meaning of thinking in action? You act and you think. You cannot think like what Asaari said, you think. No. We have this thing called thinking in action. And the other one called deliberate in action. And there's another one called, okay, act out. Okay, thinking in action first. Okay, I'll confuse this. Okay. Thinking in action. Okay, you cannot think and then do. In action, bukan off action. In action. In action. That means you are acting and thinking. You understand? You cannot like this. Assembly still. That is what Hassan said. Okay. We are thinking. Then the other one, deliberate action. Okay, deliberate action. Deliberation in action means when you want to do something, you are focused on what you have in mind. That's true. So you must act. Okay. Now we do thinking action. What would you do? It's very simple. Don't make it too difficult. I want you to do something basic. If you want to do something sophisticated, you can think about it, but very basic. Okay, so this patient is already in airway difficulty. Let's put it in. Let's try that. Because your mind is all, they call it the nickel is twisted, they call it that. No. Yeah, no, don't have that. You are kind of like clear in your mind, okay? You can visualize this patient, okay? Good. Now you visualize. Now you have to do something, like we said, thinking in action. And then when you want to act, you must be deliberate with intention. I want to eat because of it. Okay? So start with that one. So now you go to a patient. What would you do? You go to a patient. What do you do? What's the problem with the patient? Here, breathlessness. So we start with that. So, what do you think patient deserve? Even without diagnosis.
Hypermas.
You want to start with hypoma? That's fine. Okay, we start hypoma.
And then prepare for vitamin.
Alright, very interesting. So you want to prepare for vitamin. Okay? Is that okay, Siva? Why not? Well, you said not so good. But we can challenge Siva later, okay? It's okay whatever Siva said. That's fine, no problem. He said patient with blah, 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 blah. That's fine. Actually, that's not far wrong. That's okay. You know, my friend, that's okay. I quite like it when you're thinking, you know what I mean? Rather than not thinking, okay. Even if you start thinking that way, I'm happy already. Because you know, one thing Siva give them credit for it. Because they are thinking of option. Well, you are thinking about indication. At least they're thinking of it. If somebody has got no option at all, just give oxygen, I'm not. Because at least there is something that is thinking. Well, there is other ways of doing it. And IV and so on. Fine. We talk about this. You can challenge him later. Okay, the indication. That's fine. But give him credit for starting to think that way. Okay. Okay, you say somebody to prepare for that. Okay? We leave it as it is. Okay, we can debate what it is. Okay? What else? So this patient dyspneic, sweating and all that. Right? Oh, you whisper to me. Go ahead, don't worry. Everybody must know. You're thinking of ECG. But one person is now taking blood. The other one, you want somebody to take blood? Or you want to take ECG first? This is under focused investigation. Yes? See, in the thinking of changing, go straight. Okay. In the package management, after package, there's two. That's called focused investigation. And the other one is in the package management, you haven't done enough because here now you give him, you put the oxygen. Oxygen, no, you put arrow plus oxygen, and then query and IV. Query and IV. That's what he's thinking. That's fine. Okay. That's okay, my friend. At least you are thinking, right? We'll talk about it later. Okay. Next. Under the package management, because we are talking about the other one, you put another arrow the other side, there. Okay, focus investigation. We put blood too. Focus investigation. This is how you must think, okay? Because if things are, you're going to do everything one time. You ask somebody to do blood, you say, right? Blood. And then, well, including vital too. The vital is not. Okay. Blood, huh? Blood, not blue. Okay. So they're doing it for you. But we want to also emphasize on your role. You cannot be looking at them doing, right? You are doing something. That's fine then. You know, so far it's okay. Okay, one person you say, hey, I need somebody to help me. I need some blood to be taken. Okay, what blood you do that? Blood. Right. What blood you want to ask for at that point in time? What's the most important blood investigation? Blood gas. Okay, fine. That's all right. But you see, maybe blood gas another person should do. You trust a nurse to do blood gas in this department? Asklah the sister. Sister, staff nurse boleh buat blood gas? Boleh? Dulu. Dulu bukan sekarang. Okay. Boleh, let me see. Boleh. You? Dulu. Sekarang? Boleh. Siapa yang boleh buat blood gas? Angkat tangan. Itu penipuan atau apa? Siapa kata tak bagi? Siapa bos kamu? Saya bos kamu. Saya betul. I said to you, even child nurse, PPP, everybody can check. That's still I give. No problem. I want you all to be able to do it. Sure. You know, when you don't have anybody around you, whoever you can do it. So every one of you must learn how to do blood test. Because if he wants to be relied on it. Let's say nobody can do blood test. What the blood investigation? So you have a choice now. Investigation, okay. Let's just talk about the investigation and how we're going to choose. Blood gas. Another one you say ECG. Another one? Blood gas, ECG, what else? X-ray, give it to you. All the common thing you all usually do. Okay. Now choose which one you want to give. Blood gas, look around, all the new nurses. Muka-muka pembuka baru. You don't want to ask them to do blood gas, they're like, but they don't want to. Okay, you cannot use blood gas. Okay, you want to do ECG? Okay, remember ECG take time, and you cannot. You see. Do you want to do ECG? What? The patient is still dyspneic, standing up like this. How are you going to do ECG with the patient? You want to push the patient down? You see what I mean? We are training you to think. Thinking in action is to group it in a manner where you put it in a manner where patient is getting what the patient deserves. Now, if I don't teach you to think this way, you're going to be doing anything you want. And who is going to fault you? Who's going to tell you right or wrong? Because now I'm telling you to think in a sensible way. So, package management, you give oxygen so far. Blood focus investigation, you still do not know which one. You want to do ECG, I tell you. This patient just can't even lie down. I know you all did it anyhow. You just, who cares? I'm the doctor, so you do it anyhow. That's what you have been doing anyway. When we talk total quality, is that fair to the patient, Siva? Is it fair? Not fair. So blood, you want to do ABG, fine. You want to trust the nurse or PPP? Huh? Kalau masuk, boleh buat, silakan. Yang baru-baru ni boleh buat. Kamu hantar ke kerja beliau, mereka kata dan kamu semua kecau goreng dan lain-lain. Rokok, dan hil dan lain-lain. Yang tinggal yang junior-junior. So, boleh, apa yang kamu, antara kamu, siapa yang boleh buat? Acute blood gas. Boleh buat? Kamu? Seorang saja, 2 orang. Hah? Okay, so you can trust them. So maybe PPP boleh? Huh? Okay. One thing is that we have to choose the right thing to do at this time. Time critical. Okay, so somebody is going to do blood gas. Give it to you. Okay. ECG, we may have to wait. Yeah, because you haven't handled the patient just yet. I know you have done it anyway. Vital, okay, you are giving with oxygen. You are beside the patient giving oxygen. Vital is still being taken. Because you take what? Is there anything else you want to do? Sorry? You want to examine the lung? Okay, fine, no problem with me. How are you going to examine this patient? Okay, you give patient oxygen, patient dyspneic already, right? Okay, so you can't see improvement so soon. No, you want to examine the patient. Fine. Okay, what you want to examine? He will tell you.
How about the EEG and your find the patient?
Any sound?
Reduce entry.
No, sound first.
Sound.
Is there wheezing? Is there sound? Anything?
What is my wheezing?
My wheezing. What's next? What else? Who have been here 2 months? Really, how long have you been here? 3 months. Okay. Come here. You are going to next. Going to be the next. Okay. Emergency medicine is not about dancing only, okay? But that's fine, no problem. I like it. Okay, come on guys, come on. You're going to be focused. I'm working on you because you're going to graduate from the department. I mean, this one next time, they call it senafas saja. Zup, semua boleh buat, you know? It's also a matter of choosing the right thing to do. That's about all. Okay, come on. What you do next? Quickly. You want to auscultate the lung. So one thing you want to take away when you graduate from the department, the thing is called system-specific examination. So now we are training you to choose system. 1, 2, 3 system. What system you want to examine this patient and do it quickly. When we talk about system-specific, it's very searching. It's not the rigmarole or the procedure that you've been told up in the ward, because now we don't have that time. We just want to choose something quick. You understand? System-specific examination. What is the system you are going to examine? Sorry? Respiratory. And then? Okay, give you a rest because I think you are hypoglycemic. Uncle, come. Alright, so Billy, what is system-specific examination? Tell me what system you want to examine, how are you going to do it? Very clever, huh? Very political. Okay. Okay, but before that, what system you want to examine? You say cardio, respiratory, and circulation. Understand? Because this system is affecting both. Because you notice that there is patient very dyspneic, and you always worry about problem of cardiac output, cardiac of reduce blood flow, and many more things. So we might have to say cardiorespiratory, and in fact, maybe the circulation is all together. Yes. Okay, you tell him what he wants to do, and you tell him. Go ahead.
SP ada 6
Normal or not normal? Normal position. Okay, move on. Okay, the base of the lung.
Itu saya nanti ada kat sini. Boleh appreciate condition.
Okay. So, general bronchi, no adventitious sound, no fluid in the lung. I mean, he's looking for capitation and thinking about all this. Yes or no? Right? Where capitation?
Generalize.
Generalized capitation. Okay. So air entry is equal both sides, generalized capitation and bronchi. Reduced by vessel. Okay. Okay, so remember, Billy, it's thinking in action and deliberate in action. Okay, because that's actually deliberation in action. So in emergency medicine, you are not going to do what you have done in medical. Medical, you examine right through, and then you act on that. Here now, even at this point, Billy, bronchi, generalized capitation, reduce air entry. Okay, at this point, because you are thinking in action, what is in your mind? What action you want to do? Assuming you are the thinking type, assuming you are the one who's going to interpret, you interpret everything.
The package of I would think of definitely
Sure, that's fine. So you said that I want to. Now, the patient is being brought up. There is high flow mass on this patient. Yes. What would you like at this point? Because there is the flow of thinking. You are not like there. Up there they go and examine. After that they pause, they think, they wait for the stool culture and everything.
what is the BP?
Now, okay, blood pressure is by now you should get the blood pressure. If you have to look for it, my friend, that means you should be like this is what they say.
How 135 over 106.
You're very focused. Your eyes shows it. Okay, now that's fine. Attack, Billy. Attack. Come on. Now you will do now. So you've got blood pressure high diastolic, and you've got bronchi entry equal gravitation gross, reduce air entry. Okay, now action time. Because you can continue, but in emergency medicine, you find something, you can treat, you can do something. Not like you want to examine everything. I'm teaching you to think in action. Look, you find the situation already. So what would you now will be thinking? Go ahead. You are thinking of nebulizer. Just put whatever you want. You want to try give a try. Okay, just put CPAP. Just put that. Just put your option. Yeah, you put CPAP and you want to nebulize. See? You just tell me what you are thinking of. CPAP. And? Sorry? CPAP, LASIK. Okay, put that. Okay. Are you going to ask them to prepare?
Yes.
You will?
Yes.
Alright, so yes, boss. He is thinking of that. What do you feel about that? So between the two of you, how can we get pencerahan? Maybe we can get some more sleep. Are you really going to come closer? You are too comfortable sitting there. Only you can sit on that throne. Okay. Alright, brother. So now interpret what it. See? Like this, just before you. Medical officer, okay? Medical officer. You are coming next. So, everybody audience. This young Billy is now thinking of CPAP and now thinking of LASIK. Okay? Fine, huh? So, ask somebody to prepare. Okay, let's see. Who wants to respond? Medical officer. Yes, come on, guys. You, medical officer Putri? No. Who's medical officer? No one. Tak mengaku? Huh?
Aja.
Okay, yeah. Come closer. What do you think? Is Billy in the right path? He's thinking of CPAP and LASIK.
I think for me, I would choose between bypass and I will go on the LASIK first because I'm thinking more towards the effective of the situation.
Okay. What's the difference between CPAP and BiPAP? So that people know when you say, oh, you challenge him. I think BiPAP is better. I just okay. Let's tell me. Okay. You want to say something good about CPAP? Okay. Tell everyone. I want to choose CPAP because Billy, you are not wrong. Okay, you are not wrong, and you are not wrong too. All about justification. Yes. Start with you. Why you CPAP? Come on, you say. Come on, say. What is CPAP?
Okay, I mean, she can justify from the CPAP.
Don't quarrel with her. Don't quarrel. You just say what you want to say. We'll talk. You ask her later. You say what you want. What you want.
Actually, the purpose of me thinking of CPAP because I just want to push up water.
It's okay. See, why you are apologetic? I mean, you must be aggressive enough. You say, I want to do CPAP because I want to, number one, I want to give continuous pressure. Because you say what? You think that the alveoli is collapsing, there are a lot of fluid inside there, you want to drive the fluid out. Say, okay, you want to put continuous pressure, drive the fluid out, some more. I want you all to think, okay? Because just don't give answer, but somebody tell you that answer, you give. What else? You want to maintain continuous pressure, you want to make sure the fluid can rush out, and then to push out, and then what? No more reason? That's all? Okay, boss. Why not CPAP? Why you want to give bypass? What's the difference between these two?
Reduces the pressure for the CPAP will be same pressure and
So continuous, maintain. So that's the CPAP. Now bypass. Right, so fine. So you push in pressure and then you relax a bit and the pressure reduce for during inspiration. So why don't you do this? Now he feels that there are a lot of fluid in the lung. You want to push. He's even thinking of LASIK because you want to drive the fluid out. He feels that the fluid is flooding the lung. Well, you think it's infectious cause. You think that the fluid is not that significant? Okay, yeah, continue.
Yes, underlying COD.
Underlying COD. What's the benefit of bypass in this situation? You think that let me just ask this question again. So the continuous pressure versus alternating pressure. Okay. The CO2. Well, how do we know? We don't know about the CO2 retention. We don't know about CO2 retention. We know that the patient is very dysleep, very lethargic, and blood pressure diastolic is high. SpO2 you should know by now. What's SpO2? What's SpO2? You know by now.
SpO2 for implementation was 48%.
48%.
Then was under hyperthermos 72%.
Under hyperthermos 72%. Okay. What do you think of that? 72 is good enough? Not good enough. Why do you think we have such a low SpO2? Is it the fluid? Is it the bronchospasm? Is it the... See, this is a choice that you have to make. Very important choice. Please come forward and listen to this. Next time when you're in the trouble. Okay, this is the thing that you're thinking about. Everyone. We have a low SpO2 because 1. Bronchospasm. 2. Fluid in the lung. 3. Collapse alveoli. Okay, 4 is of course infections everywhere and then all that. Infection, problem of infection is fluid, collapse, maybe consolidation and so on. Which is the most important intervention in this case based on our finding. So the choice you make have got to do with this. This is the concept of thinking in action. Put everything together and now think together. Let's all think together. What is the big problem? The biggest problem in this patient? Bronchospasm, fluid, collapse. You think of bronchospasm, but you want to give bypass. It's okay. You can tell me why I give bypass. What do you think of bronchospasm? Is that correct? What's the difference? Okay, what is the issue? Now you think of bronchospasm. You still want to give bypass? Or what will be your first choice? See, why we do all this? This is an exercise of thinking, you understand? Thinking together. You know, I exercise your brain. I know the majority of you don't even bother to think this way. You don't even want to choose what's the right thing to do because you are not deep in your knowledge. You notice now we don't have much investigation, and when we go deep, and there's no protocol. All this while, every one of you influenced by protocol. Well, I agree you can do stereotyping and give protocol, but it is better for you to go deeper in understanding the patient. Well, this exercise is understanding the patient better. Now we have, what do we say? Bronchospasm, fluid, collapse, put them, infection, yeah? No, that's correct. Okay, put them, infection. Maybe there's consolidation. Maybe there's consolidation. Okay, which is the problem right now at this point in order to manage the patient right now? This is called package. Through our interpretation, through our thinking and action. Let's all agree on this. Is it the fluid? You are thinking of LASIK. Are you thinking of one time? But we put it together. You can now rethink. You think of BiPAP, CPAP. It's okay. Now I help you to put the conclusion for you. I mean, to put the facts for you. Now we think together. You can revise your idea because you have a boss that summarizes for you. Next time you won't have a boss that summarizes for you. You have to think it yourself, which is the issue now. Everybody, what choice we have now?
I think out of all the most life-threatening is the bronchospasm.
All right, okay.
We must resolve first before we treating the other three
No
orders.
problem. What would you do? What would
So
you
we
do?
will give a trial of continuous hand. Then from there we assess if patient can tolerate, then we don't need to proceed to other options like NIV or intubation.
Is that fair? What do you think, what?
I think based on the whole clinical picture, you cannot say that it's not acute heart failure because there is a generalized capitation, and also for the bronchospasm, it also can happen in acute heart failure because there is a fluid in the
It's called cardiac asthma.
cardiac asthma. So in this picture, I think really is good taking this as a acute heart failure.
Don't say Billy. They get upset with you because they have got their interpretation also. Don't say Billy, say Billy. So we just say, you can say, we can understand what Billy wants to do. But you cannot rule what he said. That's not wrong as well. It's a matter of choice. Right now you feel that bronchospasm is affecting them. But you say, this patient may need heart failure. Okay, in any case, just say what you want to do so that you can justify your action. And you notice therefore, it's not right or wrong, okay? It's about why you do it. Is that clear, Siva? In exam, it's basically the same thing. Somebody can say, I want to give, like you say, try. I won't fail you. I think that's perfect. And you say, I'm thinking of congestive cardiac failure, I worry that is a bronchoasthma, that is a cardiac asthma, and I want to think of fluid. Not wrong. But then she will say, no, I think of infection, which I said just now. I think this is infection. Maybe there's some consolidation infection. Okay, you will upload the blood pressure. Okay, upload the blood pressure is actually high. And whichever, you see. You notice that there's not one right. That is all possibility. If you start with that, to me, it's not generalized bronchi. That is an issue about the bronchioles and the bronchospasm and so on. You may want. And how certain can we be as far as cardiac asthma is concerned? We cannot be certain. As to what's obvious is that. But you're also correct. Okay, I want to think fluid. And somebody said, no, I think this patient is infection. After all, just discharge from IPR. So, where is the overriding wisdom? Who's going to say the grand wisdom?
But I think there's
Wait, we can argue first. No, argue. No, you don't wait for me. Me, I give you protocol directive. Somebody say why you say that. Everybody can say I'm not infected. I tell you at home, nobody will listen to me. You know, my daughter said no, that's wrong. I have to say.
My opinion, because at that time is acute management because we should give nebulous and we do ECG.
You're correct. Your first sentence, this is called acute intervention. Okay. Right. So continue.
Then we can proceed to rule out other causes. We can do ECG to rule out patient having any ischemic changes. Then we can do chest X-ray adjunct, and then we can add on.
He said, I want the bronchospasm, release the bronchospasm.
We need to assess whether his patient is overload ke ada lung lowering edema.
Wait. No, this one, because he hasn't finished the investigation. Yeah? He hasn't finished the finding. Yeah? I just want to insinuate. I actually want to inject at this point, interject at this point, to say that process of intervention can actually change once you start examining. Some of you wait for a while until you see everything. Some even, oh wait, better change right now, you know, because if your examination takes too long. But if you just quick, that's the reason why, everybody please listen, that is the reason why I call system-specific examination, because we can't afford the time. Time critical, like I was talking to them just now inside that myocardium time. So you cannot just examine and start thinking this, that, and finally patient collapse, you're still thinking. That's what they do in medical. Okay, so which one? What do you think? He said bronchospasm first.
First of all, yang NIV itu there's nothing wrong if you start CPAP or BiPAP.
Nothing wrong.
Okay, then based on your interpretation, you said because CPAP or BiPAP is just to help the work already for the patient. But the main problem is now is bronchospasm, right? So we need to reverse the bronchospasm by giving some initial treatment. So that what we did is just agent bronchodilator lah, bronchodilator.
What's the problem with giving this bronchodilator if you're not care? Because you're worried about consequences.
Because now also patient has a high sympathetic drive, hypertensive and tachycardia. If you give another beta agonist, then it become more. So if the patient has heart failure, then it will worsen the condition.
Okay, both are correct. But this is the overriding wisdom. I'm the boss. Simple. It is nothing wrong in giving bronchospasm. What he said is very clear. You give it and you see whether the response of this patient. Because at the end of the day, the effort of breathing, if you reduce the effort of breathing, even if you have this, you can reduce congestive cardiac failure. The heart is failing because of the respiratory problem. Is that clear? When we say cardiorespiratory problem, remember that statement I made? Because now I believe that the heart problem with all the catecholamines is actually due to the lung problem. So now we have to manage the lung. So if we start off with bronchospasm, management the bronchospasm, it actually may help the heart. Is that clear? We work on that premise. Did you do that? What did you do anyway?
Actually, I give a trial of the nebulizer.
Okay. Did you give it a try?
Kalau patient due to patient having severe shortness of breath, so patient after 4 minutes patient
cannot tolerate.
So I proceed immediately with NIV, BiPAP, and combine with.
Okay, the issue about whether BiPAP or CPAP, it is actually quite safe to start with BiPAP first, because if you continue giving pressure, if you are dealing with lung infection, collapse from there, you may actually break the bullae and you may cause pneumothorax. So that BiPAP is less aggressive, but if it helps by that way, then fine. You can also try a BiPAP. Okay? So we say bronchospasm not working, so you give BiPAP. So what happens to the patient then?
Patient able to tolerate BiPAP. Patient more comfortable, able to lie. It's now in the type of position now able to.
So patients more comfortable with BiPAP.
Comfortable with BiPAP.
Oh, okay.
Combine with nebulizations.
So BiPAP nebulize. That's all. What about LASIK? Have you think your LASIK? Yes, no?
Not given
Not yet.
because
Okay.
no epidema.
But he said to you, you don't have to wait until then because congestive cardiac failure. You come on. I mean, the epidema is never a diagnosis of never. Don't say that. You don't say because there's no epidema, I don't think of cardiac failure. No, cardiac failure can still happen. In fact, if you look at the blood pressure, the diastolic is quite high, but that could be due to catecholamines all over. But still.
Then improving.
Okay, what's the blood pressure and heart rate now?
Pressure rate now is 100 162 over-rectify.
So, improve. What's next? So now you proceed with the... Okay.
So, I do take this ECG.
So patient can lie down now, comfortable. So you want to do ECG. Have you done ECG? What is ECG going to do?
Sinus tachycardia.
Sorry?
Sinus tachycardia.
Sinus tachycardia and give it to me. One of them. Yeah, interpret. Yeah. Sinus tachy only. What should you be looking for? What are you looking for? That's what it's all about. Just give me the relevant negative. You see, when I was young, this is how I was trained to see ECG. You know what? We all did. This is how I was doing when I was young. Zoom! Like that. Finish. But I have in mind to look for something. And I want to say the relevant negative. First tell me, when you look at the ECG, you expect to see tachycardia because the catecholamines all over, okay? So that's no big deal. If you tell me tachycardia, I will tell you, big deal. Okay. But next you must tell me the relevant negative. What is it that you are looking for? And it's not there. No ischemic change. Okay? Come on. Yes? Okay? Anything else? Most important. Rhythm. What about rhythm? What is it you're thinking about? Rhythm. AF and you must always think of what? Arrhythmias. Because all these are indication of what are the indication? Because when the heart starts failing, the system will go haywire. Tachycardia alone is fine, but if it is with some dysrhythmias, although there's no some arrhythmias, some misbeat and all that is indicative of the heart is actually in trouble, in some sort of trouble. Okay? Now, you look at it and tell me in a while. Okay, so ECG, okay, let's say we take it as what you said. Tachycardia alone, only. No, I'm not interested in that one. Not yet. No. Blood pressure. How long will it take? 10 minutes. How with FBC? Did that come out? How long? Yeah. Now. 2 minutes. Okay. Hang on. Yeah, before that. Because the idea is this. It doesn't help. That doesn't help. Because it's better for you to interpret from now on. We are worried about cardiorespiratory problems. Okay. If the lung infection, we actually have in our mind lung infection anyway. But lung infection will not kill. We are looking for something that can kill the patient like this. That's the reason why Lokman said, be careful of heart failure, because that can kill the patient. And somebody said, be careful of the problem, bronchi on board, that cause problem. So these are the things that we are not thinking. If it's lung infection per se, fine, good, but then it's not something that we need to worry. Just like, at this point in time, we want to rule out. That's why I asked him to tell me the ECG, whether there's anything else you worry about.
Okay. Then there's no arrhythmia like sinus lesion. No left ventricular.
Okay. So, anything else?
I just want to ask, we do reverse, we treat the heart failure first. Within patient become maintain. What do you think? If you treat as a heart failure.
What's the indication? What do you think? Okay, these young doctors do not have in their mind heart failure. She said infection, and somebody said more of bronchospasm. But why is the bronchospasm due to? You say cardiac asthma, they probably say about some form of lung infection.
Maybe patient become better because we start on bypass.
Okay, bypass help the patient. What else did you do? You do nebulize together. Belum lagi nanti dulu. Boleh buat chest X-ray, but we have this package. Okay, let's just think about this. Yeah, we are now doing immediate investigation. Now we can go a bit further. the focus investigation better with your blood and ECG and also chest X-ray. Okay, just hang on there. Patient has improved much better by giving BiPAP and nebulizer. Patient can lie down. You can do ECG. Now with ECG, there's something much unique. Oh well, there's nothing there much to say, but we anticipate that already because there's already catecholamine and we can see blood pressure. But what is your heart rate now after you give nebulize? About 10 minutes or so?
Reducing from 1174 to 119.
Okay, you see some response. So now you want to do what do you want to do? Okay, the blood investigation may come back by now. You can do ECG, you can do X-ray if you want. You can do X-ray if you want. Okay. Which one you do now? Patient's comfortable? Is it much comfortable more? Or much more comfortable? Yes? What is the respiratory rate?
Respiratory at that time was 26.
Okay. So which one to do? Which one? You want to do X-ray? Okay. That's the reason why I designed this department with an X-ray. We don't want to send patients too far away. Even if they go, you understand? That's why you see what orang bagi tahu, Ibu Andi, ini mau nak di sana. Jauh-jauh. Ya, sekarang kita bikin X-ray, ronsen. Kalau di ronsen. Bikin ronsen dalam jangka masa 2-3 menit. Tapi mungkin lebih mungkin sampai 10 menit. Okay. That's one reason why kita tidak perlukan itu untuk bikin sesuatu. Itu mungkin datang, itu fase kedua. Fase pertama, kita nggak perlu apa-apa. Kita mau bikin intervensi berdasarkan apa yang kita lihat, apa yang kita examine patient, yang kita lihat, itu kita bisa sudah bikin. Ya, sekarang kita sudah bikin tanpa itu, dan patient sudah bagus. Sekarang sudah lebih enak, lebih selesa, dan bisa dibaringkan, bisa dilakukan EKG dan lain-lain. Okay. Jadi, okay. Now we move to the second phase. This phase is about the blood finding, the X-ray, and so on. Okay? So blood, you say, put blood down. We got that about 5 minutes. Yeah, in 5 minutes we can get it. Yeah. Okay. Okay. Then we did X-ray. So, who wants to interpret? Put properly. X-ray. This one shot, okay? Billy, where are you? Okay. Oh, yeah, okay, Dato. You can say next. Are you involved in patient care? Quick. Only 1 or 2 seconds, one look, and then give me what you see. Go for the gross thing, okay? Learn how to see gross, big picture. We don't look at small picture, big picture. Okay? Now, one more.